Medication-Assisted Recovery Support Project, MARS. It's a SAMHSA CSAT-funded initiative developed and carried out completely by people in methadone treatment. So, you know, as our RCO, Rikers is very excited about that. In collaboration with Non-Recovery, which is a patient-driven national organization representing interests of people with interests of OTP patients. They've now been able to expand their reach through trainings in the US and in Vietnam. Now, our speaker, Dr. Joe Sotheran, is a PhD from Rutgers University and served throughout the MARS project as its consultant evaluator. And they use multiple methods for this. She's presented on the MARS project at the American Association for Treatment of Opioids Dependence national meetings, the American Public Health Association, and the American Sociological Association. Within their treatment field, she has served at the AATOD Workshop Committee, the SAMHSA IDIQ Review Panel, and a consensus panelist for CSAT TIP 43 MAT for opioid addiction in OTPs. So I'm very happy to introduce you, Joe, and you may take it away. Thank you.
Okay, so I have the floor now. Okay, welcome everybody, and thanks for putting up with all the glitches that are mostly my fault. But I'm absolutely delighted to be here, and I'm going to talk about the integration of peer recovery services into methadone treatment. The general plan for the evening is that first of all, I'd like to acknowledge our hosts, Rikers, Cobre, and Brown. And John had asked me to talk about peers and stigma specifically. So that leads to a discussion of peer leadership and recovery within methadone treatment, which is itself a highly stigmatized and structured type of treatment. So there's kind of an interesting paradox baked into this. How do we encourage the kind of sense of freedom that recovery can bring by at the same time having to situate everything within a highly regulated treatment modality and work for it? Well, the answer is it can be done, and I'm here to tell you about it. I'm going to talk a little bit about the integration of recovery into methadone history, and then talk about the evolution and features of the MARS project and what we found out about stigma and peer support. The sort of plan for the evening is a little bit of background on methadone stigma regulation and its population, because many people really don't know about this, and it's important background. So we'll do a little background on recovery and methadone, how it got started, what its common program elements, treatment are, how recovery, stigma, advocacy, peers, and education all fit into this, and what we've learned about peer support and stigma. If you leave with nothing this evening except a slightly better education about how methadone actually works, I will be pretty satisfied. So a little bit about me. As I've been introduced, I've done all this stuff, and I've also been actively in volunteer methadone advocacy for a long time, which is why the MARS project trusted me to sort of understand what I was doing. I occasionally get careless and lose track of who I am. I am blonde, and occasionally slip into talking about it as we, because I've been with MARS so long, and I'm sort of possessive about this. But anyway, let's stop for a second or two and just ask ourselves, what do we think about when we say methadone or methadone treatment? Give yourself about 5 seconds to think about that and form an image. Okay, now, Do we see these as coexisting with recovery, or part of recovery, or opposed to recovery? Think about that one too. Okay. So now we're going to briefly review how methadone works and for what, and a very brief history of it. And then a little bit about the concepts of recovery and their evolution, especially in the SAMHSA realm, that of doing recovery. And sort of process orientation and new application to MAT. The reason, by the way, that I titled this presentation Doing Recovery in MAT was two. One was current definitions emphasize recovery as a longitudinal process where there's ongoing whatever. So that's a common denominator. But also, doing this in MAT was brand new. We had a plan, but nobody really knew how it was going to go, and so everything was new. And I concentrated mostly on describing what actually happened, because there were some surprises. So to repeat a little bit of educational stuff at the risk of boring at least a few of you, what do you think you know about methadone? Answer in many cases will be not much. The other will be nothing very good. But what it actually is as a medication, it's an addiction med. It can be used as a pain medication. That's how it was originally developed. It's a synthetic opioid. Its use for addiction was really discovered almost by accident by the famous Doctors Dole and Niswander in the late 60s, kind of the founders of our field. It's classified as what we call an opioid agonist, which is fancy talk for talking about it doesn't oppose another opioid like naloxone bounces the opioids off the opioid receptors temporarily. The opposite, an opioid agonist fits right neatly onto the opioid receptors and doesn't let anything else in. So it sort of takes over a piece of your brain. It mimics other opioids in many of its aspects, except it has different side effects and it's socially different. In terms of its side effects, it's long acting. Most street opioids are fairly short acting. You take it and a couple of hours later, it's gone. Methadone is long acting. It stays in place and doing its job for 24 to 36 hours. And it's also socially very different. It is used as a treatment rather than a way to get high. Now that means since it's filling the opioid receptors in the brain, other opioids cannot go overriding it. That means if you decide to do a little heroin on top of the methadone, nothing will happen. So that there won't be any euphoria. And the methadone itself does not give you any big euphoria. It just makes you feel sort of normal, as people describe it. And most important for opioid users, it blocks the cravings and, more to the point, blocks withdrawal. Just mention withdrawal to an opioid user and you will see that what a big advantage that is. Any opioid user who's become accustomed lives in absolute terror of withdrawal because it's such an unpleasant experience. So another difference from it is a long-acting opioid. Instead of having to use it on the street, you would use heroin every 4 to 8 hours to keep the withdrawal away. With methadone, the half-life is 24 to 36 hours. So if you take it every day, that keeps the level in your body and brain more or less level. As one day's dosage is beginning to sort of fade away, the next is coming in. And the level of opioids in your brain is fairly stable, and that makes you feel stable. The thing that we always forget about, and this gets lost in a lot of the dialogue around how we ought to get rid of the DEA and be able to dispense methadone anywhere and everywhere, which in many ways one would agree with. The danger we forget about is that it has all of these opioid blocking effects for people who are accustomed to it. But for people who have no opioid tolerance or have a very low opioid tolerance, you drink somebody's bottle of methadone and you can easily be dead. The dosage is titrated to your exact level of tolerance. And every year there are a few episodes where somebody gets killed from having a diverted bottle. Worse yet, sometimes it's young children who see these bottles of something that looks like cough syrup or cherry syrup out of the refrigerator. So this is what we always have to be looking at is the danger of diversion and unintended use. So it's originally synthetic, but it's originally derived from morphine before World War II. Interestingly, the rush from it, if you get one at all, is very, very slight. So it leaves you feeling relatively normal. It also, however, and this is the downside of any opioid, it builds dependence. Once you're dependent on it, your body is going to know the difference once you don't have it. With street opioids, your dependence increases. So over time, your body gets used to a particular number of milligrams of morphine or heroin being in your body. It gets used to that, that becomes normal, and it starts asking for more. That's why people start injecting more and more often. The habit becomes more and more expensive. With methadone, this pretty much, and as the saying sometimes goes, after you've had a street habit for a while, after a while, you don't even worry about getting high anymore. You're not going to enjoy it. What you worry about is getting straight, which is to say, getting your dosage to where you can avoid the withdrawal. That becomes the big motivator around what you do every day, hustling the cash. You've got to do this regularly because, every 4 to 10 hours, your body is going to want it, and you don't want to risk getting thrown into withdrawal. So my talk is going to be, first of all, to ask you a little about, your opinion. And I will say right now that most of you, when I asked what you thought, did not think anything very flattering. People usually don't. When we talk about stigma, well, stigma is the middle name in methadone. There are very divergent reasons for it. There's a side that thinks, oh, it's just another drug. You're substituting one thing from another, all that. From the other side, there's, oh yeah, methadone is great, but we need to break down all the regulations. Everybody should be dispensing from pharmacies and sidewalks and who knows what. And the reality of things as they are feasible now is somewhere in the middle, of course. And the role of recovery in all this is kind of complicated because in the general recovery world, we tend to contrast treatment to recovery. Like recovery is what happens in between episodes of treatment or after episodes of treatment or supplementary to episodes of treatment. It's generally a separate thing. So what does, methadone patients, as we know, have to go into the clinic relatively frequently. They're caught up in a rather restrictive clinic system. So what can all of that have to do with recovery? And can you be in recovery at all while you're on methadone? This is always a hotly argued one. Can methadone patients think of themselves as in recovery? And in essence, you are bound into a rather restrictive structure. And how can you think about achieving personal freedom within this relatively tight set of regulations? And even more important, will other people think you're achieving recovery? This is always the big problem. And there's a lot of historical difference. People can use methadone in a lot of different ways. It is, when you get down to it, a specific medication. Some people regard, and these are orientations in the treatment field as well, some people regard it as, well, it's just a medication. You don't need anything else beside that. Then there are the people who say you need the medication, plus you need psychosocial and wraparound comprehensive services to get the most out of it. There are people who use it only as a harm reduction tool. And these are especially street users who will sometimes use it just to get through a tough period. And some patients who just don't want to be bothered with the personal transformation piece of it. They just want to stay stabilized. There are also huge numbers of views on regulation and how should we be regulating this. You can get into something resembling a fist fight in certain circles for suggesting that, well, some of the regs do have a point. But now, what does it feel like to take methadone for addiction? And full confession here, I'm not a patient, never have been. I've just hung around in patient circles for a long, long time. It's, by government sources, it's regarded as the, quotes, gold standard for opioid treatment. Nothing works better. It's a medical modality. We understand what the mechanics of it is, the chemistry, so all that's pretty good. That's why it works so well. But how is it different? Well, heroin usually feels good, especially when you first start using it. People talk about it feeling warm, cuddly, there's kind of a rush to it. This is all very nice. Unfortunately, when you've developed the dependence and then you are deprived of heroin, it's not so much fun. It can be like miserable withdrawal, and it can be even sometimes be life-threatening. So methadone is, in contrast, long-acting versus the short-acting. And it has two really key properties. It blocks the withdrawal for 24 to 36 hours. You also cannot, or it's very difficult, to take another drug on top of it. It plugs the opioid receptors so thoroughly that even if you try injecting heroin to somehow top it off, people who do that usually get disgusted by the amount of money they're wasting. It just won't work unless you're using huge, huge amounts. So it also doesn't produce any particular euphoria. You take it and you feel, at best a slight buzz for a little while. Then you feel kind of normal. And in fact, there's even been a film once made called The Joy of Being Normal. Sort of, we don't have to worry about this stuff anymore. So at the minimal results of methadone are, in the treatment system, is that you get a measure of stability. The bad news is you have to show up fairly frequently, at least in the early stages, but you do get a certain amount of stability. You don't have to be endlessly hustling the money to purchase the next bag. That's the big thing of heroin users spend an astonishing amount of time just trying to get the next piece of folding green to pay for the next bag, which will head off the next withdrawal. And it gets to be quite aware, really. So people get stable, they don't have to hustle for money anymore. And it opens up their possibilities in time. All this time that they're not running around trying to chase the money, trying to chase where the dealer went. Well, did you hear that, the cops busted so-and-so, we got to find another dealer. This can become serious lifestyle stuff. So that pretty much goes away. But what's it like being in the everyday world of OTP, or as we call them in the United States, opioid treatment programs, because methadone for pain, and it still is used as a painkiller. It's relatively cheap and works pretty well. That can be dispensed by any doctor with a DEA license, and some still use it. But if it's for addiction, it has to be dispensed only in a federally licensed opioid treatment program, which means a lot of regs. The environment as a patient will be very structured, pretty regulated. The degree of regulation can vary from tolerable on to awful. It means you have to do regular visits, usually between certain hours. You can't just walk out with a few bottles. You eventually do get take-home doses, but they have to be earned by basically following the rules and progressing, showing progress in treatment. To get into methadone at all, you have to have a medical exam, and the initial intake period can be sort of uncomfortable because they raise your dose very, very slowly. That is to find first what's the therapeutic dose for you. The other is to prevent killing you, because they don't know how much opioids you've got on board when you come in. So the rule is to go rather conservatively day by day and, check back. And is there any right dose? There used to be a little bit of a debate about, well, how much should you take? And some clinics still have unofficial ceilings. There are some where you will not get above 120 milligrams. Is that adequate for some people? No, not really. The right dose, and some people can go to a couple of hundred. The right dose is very individualized. It's enough to block withdrawal, period, and leave you comfortable. Individual clinics can vary in how willing they are to take things higher, and some of them impose formal dose caps, but there's no magic formula. So what's the actual OTP environment like? I suspect most of you have never been inside one. The answer is it's kind of dull when you get down to it, when you think of all the people, all the things say about it. The environment includes a fairly large patient flow. There's some fairly strict confidentiality regs, which is why we cannot just walk into a clinic. There are a lot of structured protocols for taking your dose. You every now and again have to show up and take a dose in front of the nurse, and getting take-homes. There tend to be limited hours. It's not like there's a mobile station on every corner. There are parts of the country where there are limited distributions of clinics. And then there's a kind of variable workforce and philosophy, which we see at like methadone conferences. There are differences. Some people are in the highly medical realm, where you simply stop the opioid cravings and you kind of leave the rest to itself. And then there's, another wing which sort of says, oh no, this is all highly psychosocial. The medication is just a coincidence. Do we sanction for alcohol use? Do we care about marijuana? Do we care about benzodiazepines? So there's a lot of difference. And to some extent, and this is sometimes reflected in the amount of staff orientation and training, which can vary a lot depending on state regs and budgets, and the comprehensiveness of services on site. The one we work with, for instance, has on-site primary care, a psychiatrist, and HCV and HIV treatment. It's wraparound. Other treatments, other clinics, you would have to be referred outside to who knows how accessible it could be. So there's a huge variation. Now, who are the patients? They tend to be either heroin or pills, or both. There's been a big rise in people who got habituated to opioids through pills in recent years. It's meant clinics have started opening in places they never were before. There's some differences among the patient clienteles. There's also regulations differ by state, insurance and payment differs by state. And then there's the patient makeup. To even get into methadone, you're required to have some prior treatment attempts that haven't worked very well and be in active withdrawal. So you can't just walk in and say, give me a cup. The patient makeup nationwide has a tendency to be kind of low resource, often lower income, often racialized, lower education. In terms of what we see psychosocially, you see a lot of polydrug abuse, fairly high percentages of mental health conditions, and a lot of physical health deficiencies. Methadone is not a first-line treatment, really. It's for people who have tried a few other things and they haven't worked. So getting on to the topic of our talk, which is the history of recovery movements in the 2000s. This was about the time when the Substance Abuse and Mental Health Services Administration, their Center for Substance Abuse Treatment, took over regulation of methadone from, oddly enough, it was regulated by the Federal Drug Administration and regulated purely as a substance, a drug. Well, SAMHSA took it over, and they started kind of looking around and realizing that in general, first of all, the usual treatment doesn't always work. There are gaps in treatment, and they started thinking, well, wait a minute, recovery is what comes between episodes of treatment, or maybe it comes afterwards, but it's a separate process. They started reading and publicizing a lot of William White and similar authors who proposed the idea of recovery as a process, it's a journey, it's personalized, it's about self-transformation. In other words, they really didn't say anything about abstinence from particular substances. There was this idea of personal, we should say metamorphosis, butterflies hopping out of caterpillars. And as SAMHSA began to put money into the recovery movement, two things happened. One, it began to become more of a social movement. The whole idea of a recovery community organization was not known 30 years ago. And they started having grants, which was good. Now, where at the time was recovery within the opioid treatment program world? And the answer was mostly nowhere. There existed the National Alliance of Methadone Advocates, now known as NAMA Recovery, which was founded in the 80s by a group of actual patients. And they spent a lot of their energy on education about methadone, knowledge is power, quality treatment, patient advocacy. If you're interested they have a huge library at www.methadone.org. And I have to credit their longtime executive director, Joycelyn Woods, she was a former office colleague of mine and got me interested in this stuff. They also are very interested in patient representation and sort of coincides with the recovery emphasis that's been coming out. But how do we do recovery in OTP? One of the reasons I called this presentation Doing It is because, first of all, it's a process. We don't know where it's going. And also, it was a brand new project. So we didn't have a clue what was really going to happen. A lot of it was making it enough up from what it went along. So the Mars project itself has been influenced by, I think, three major things. There's the whole recovery scene and its growth, which is not, I have to say, been terribly welcoming to medication-maintained recovering people. And then there's patient and personal experiences that people had in recovery. And there was advocacy experiences within the OTP world. Now, go back a little bit to the regulatory system, you'll see how complicated it is to squish patient recovery activities into a methadone clinic. From the top, visualize this as an inverted pyramid. There's the Food and Drug Administration, regulates it as a drug. The Drug Enforcement Administration worries itself sick about diversion and licensing. Then there's the Substance Abuse and Mental Health Services Administration, which took over the general oversight of methadone treatment in the year 2000. And something else new, clinics now have to go through a formal accreditation process, just like hospitals and other treatment programs. And underneath that, there are state regulations, which cannot be any looser than federal, but they can be stricter, and they vary from state to state. And then the clinics can themselves make regulations, provided they're no stricter than anything above it. So where are the patients in all of this? Yeah, they're on the bottom. They're sitting there looking confused because this is all a lot to follow, and in everyday life, there are all kinds of things that don't seem to make sense, and sometimes somebody behind a counter will simply say, yeah, well, it's the regs, we're sorry. But the other thing that happened during that period is that we see the launch of an organized recovery movement. It had its historical roots, namely in the work of William White. But SAMHSA got interested in it too and began promoting it very aggressively. The whole movement tended to talk about common recovery mechanisms, including the self-transformation, the slow but steady changes, usually the use of groups and identities, and groups and interaction. And then there were identities. So this kind of set the stage in the early 2000s. I'm going to just sort of wave for a minute or two some graphs a little bit on what we see in stigma processes and how little way we've come. These were taken from some baseline supplemental interviews we did. We have 47% say they've been hurt by somebody because they were on methadone. Well, all right, we would expect that. Only 47% say they've had a really bad experiences, some of which can be very bad. 48% said they would be worried about self-disclosure, that something awful would happen. 29% say that they are worried that people around them would be disgusted and say, oh, look at that. 75% would advise their friends and family not to disclose. In other words, be careful who you tell about this stuff, which tells you something. You can't really go around talking about being in recovery and everybody saying, oh, congratulations, because it'll get down to the question of what are those little bottles of red stuff? And isn't that a contradiction? And then we also have some data on knowledge and attitudes about various aspects of methadone. These were done at our baseline interviews. 91% said, yeah, it's changed my life for the better. 89% said, yeah, the counseling helped some. 60, but there were some other things too. Quite a few of them believed, about 43%, that it really does rot your bones, which is total myth. Then there were 66% said the clinic system was a headache, and most kind of disturbing, 70% said they did not tell their doctors that they were on methadone because they anticipated there would be some very negative feedback. They might get inadequate pain relief, discrimination, who knows. And 63% said they didn't tell their own friends and family about methadone. So there's a lot of people worrying about stigma. So this makes for a lot of challenges in how do we design recovery and anti-stigma work around OTP patients, partly because they're stuck in the clinic system, which is not always welcoming, and there's a lot to overcome. So some of the strengths that they do have that we can use are, first of all, accepting them to accept and understand the medication, teaching them that this is not a sign of moral failure, or some awful brain condition. This is a medical condition. It can be treated. And giving them some factual info about how, yes, heroin using does tend to modify the brain chemistry a little bit. And okay, so this is a brain disorder at this point. And what you're taking for it is called a medication. You would call insulin or aspirin that. So look at it as a medication. But we didn't necessarily trust the clinics to deliver that information. In fact, there's a certain level of distrust of the clinics by many patients. There's always this sort of, they're trying to manipulate you, they're trying to wring the insurance out of you. What do they know? They're just a bunch of 25-year-old social workers, whatever. So you want this information to be delivered by trustworthy peers, people who actually know what they are talking about. And a strength in the patients, it's a mixed blessing, but they have multiple disadvantages. At most clinics, the background in terms of education, race, income, incarceration is not that favorable. We have a startling number of people who read at maybe 5th grade level, and a lot who have been incarcerated. On the other hand, they're older. A methadone patient much under 40 is not that common. They've been through other treatment attempts. They kind of know what's going to work and what's not, so they're fairly serious. And then we can modify the environment a little bit. We can provide companionship and role models. We can provide information that the clinic may not be telling you, and make ourselves available to answer as many questions as possible. We are sort of locked into the clinic system. It's very hard to do this outside. And one of the reasons that the MARS program has to be done in clinics is because the clinic system does not encourage you to congregate outside the clinic. There are usually regulations about loitering. The thing that you might normally do, which is go to the donut shop with a friend or two and talk about this stuff, is a no-no. So you have to locate it. You have to locate it really inside the treatment system. So what are the solutions to all this? We had it sponsored by a patient advocacy organization, NAMA, which had been around the block a bit. We were able to get a large clinic to cooperate. We approached a couple. They didn't understand what we were doing. But Albert Einstein, which is the second largest chain of clinics in New York, sort of got it. Their leadership understood it. So the arrangement was that we would collaborate formally, but independently within the clinic. Legally, we occupy a separate status. We rent space from them. There's an iron wall of confidentiality between MARS and clinic operations, etc. We would rent space, and the MARS staff would all be patients, so of varying, makeup. So they would be role models. And then peers would develop the materials and the curricula. And a few peer leaders would get modest stipends to come in once a week and conduct one of the groups and generally be kind of, available. And it became to be a real privilege to become a peer leader. People were very competitive about it. It was very nice to see. So some of the program features, how do we think that the peer support really works? One important thing is it's voluntary. The treatment system is not requiring you to go to groups. You're going to it because they have a coffee urn and it's kind of fun, and you might learn something. And everybody in the project is a patient. So there are role models. The only two exceptions are two of us who fill technical roles. I'm the evaluator, so I have to have some objectivity. And the other is the woman who does the training. She's a curriculum specialist, but everybody else is a patient. Now, the core goals of the program are to increase the knowledge of how MAT works. And that would improve retention, which is one of the things the clinics were interested in, and success. More information would decrease stigma. People would accept the idea of this as medication and be able to stand up to their friends and relatives. And it would also develop just a recovery environment and identity, a comfortable place where people could go and be around people who were like-minded and talk about whatever. So the groups became key. And the questions I had to it were, what are the topics going to be? I had no idea. How were they going to be run? What were the group processes going to be? How are these groups supposed to contribute to recovery? And how did they differ from treatment groups? That was something I was really interested in. Now, how these are about recovery is they basically produce social support through processes. But how do they differ from treatment groups with the similar names? This gets to the essence of recovery. This came home to me one day when I walked in, and it was we occupied some space at the back of the clinic. But I stopped to look at the clinic bulletin board, and there was a flyer advertising a new group at the clinic, and it was called something or other. And I said, wait a minute, we at Mars have a group with the exact same title. How are these groups different? And that led me to think about the whole thing very differently. It got me looking at what are the processes involved. And after I sat in on quite a few groups and just went and, did not take my notepad, just dropped in and sort of watched. And at first I couldn't figure out, what does this have to do with, what does this conversation have to do with recovery? And then I identified, it took me a while, but I came to the big revelation that what I had to be looking at was not the topic of the group. It was, what are the processes going on, sort of an interactional approach. And I identified these as 5 key ones, which I labeled enacting a normal life. And that is, people talk about normal things, what they did over the weekend, hair, clothes, makeup, this sort of, everyday thing that people talk about, which you don't normally in a clinic. It's a way of kind of building relationships. And there's also, very important, the validation of people's perspectives. People will talk about some incident or situation that happened, and other people would join in and say, yeah, that's the way it is. In a treatment group, they might not do it, but everybody would sort of agree with most of what people said. So it's making the participant feel like he's the authority about his own life. There was also what I sometimes call troubles talk, which is where they're talking about a situation that's a personal trouble of some kind. Boyfriend broke up with me, I'm getting evicted, this kind of thing. And in a treatment group, you would normally kind of deflect that because it's a personal problem that doesn't relate to the group. But in the recovery groups, what would happen would be that the other group members would seize control of this. And there could be either information offered, which was practical and concrete about the problem. Oh, you have to go to the Office of Rent Control to get that fixed. Or there are rooms to rent, at that price on this street. In other words, concrete information. Some of it was more opinion. And this tended to happen a little more in men, actually. But there would be, you should do, you should say. Sometimes it was surprisingly sophisticated. I was, pleasantly surprised to see how practical a lot of this was. And some of the problems were messy. So sort of wrap this up, I started asking the questions, how do recovery groups relate to treatment groups? What's the big difference? We're all using the same titles, we're drinking the same lousy coffee in the same conference rooms. And it's important to be able to delineate peer recovery. And part of the answer was in their purpose. Treatment groups have a tendency to want to provide knowledge, skills, etc., towards reducing substance use. That's the ultimate theory of change they have. The peer-led groups are more about reducing isolation and a self-chosen topic. The topics can wander all over. In terms of leadership, in a treatment group, the leader is directive, and she is responsible to an external force, either the agency or the payment model for the group being exposed to certain kinds of techniques or information. With the peer-led groups, it's very facilitative. The person who's running it is responsible to the group for keeping order, making sure that nobody gets too much out of hand, that kind of thing, but that's about it. The group, in many ways, really directs the content. In terms of topics, treatment groups tend to be linked, at least theoretically, pretty directly to substance use. If you're going to talk about, say, domestic violence, it's because you're viewing domestic violence as either a precursor or a result of substance use. In the peer-led groups, the topics are variable and they're selected by the leader or the group. Some of them are very pedestrian. As far as how individual troubles go, when somebody, as I thought to thinking of it, dumps a problem on the table, in a professional group, you'll deflect it, you'll redirect it, or you'll say, oh, we'll talk about that later. You don't want it becoming community property. In the peer-led groups, that was where it is entirely legitimate. All sorts of people had, support and or advice, some of which was good. And finally, the focus in the treatment groups is about treating the disease of addiction and its socially defined signs and symptoms, whereas the negative effects in the peer-led groups, what you want to focus on is the negative effects of a chronic disease as defined by the individual. If your problem is giving you trouble with your family and household, that's what the problem is. It's not about the fact that you happen to be using a lot of crack. So with that, I'm going to apologize for running a little bit late. Open for questions, which I am more than interested in. And I'd like to announce that somewhere out in Zoom land, we have our Mars founder and project director, Walter Ginter, who knows the answer to everything I don't. So whoever is in charge, take over.
Thank you so much for that, Joe. I really enjoyed it. And if you do want to send me those notes that you had that you were reading, send it to me and I can distribute that as well if you'd like to. Yeah, so anybody with any questions can put them right into the chat. I don't know if there's a raise your hand, but if you'd like to speak, just say that right in the chat. All right, can I have you unmute yourself, Diego?
Yes. Hey, everyone. Thank you so much for that really wonderful presentation. And my experience in supporting peers on a methadone-assisted recovery pathway has been very variable. I've worked with someone who was on methadone for many years and was very stable and who owned a car and had sort of jobs and gigs. And then I worked with someone who really was more on the harm reduction end of the spectrum. The methadone was like, they got the bare minimum to not go into withdrawal. And even then, it didn't seem like they were probably getting enough, based on sort of some of the things that you said. But, you know, they also were still an active polysubstance user aside from opioids. So I just wanted to throw some of that out there. You know, in your experience, someone who is on the harm reduction end of things, who may be actively using a whole bunch of other substances, what is the methadone doing or not doing for them in that case? And I believe they were still using opiates as well.
Oh, this
So
would,
I'll just leave it at that. Yeah.
yeah, this is sometimes very common, especially the polydrug, because what I maybe have neglected to mention was that opioids are, methadone is specific to opioids. So people come along and say, oh yeah, but he was still using cocaine. And all you can say is, well, you know, methadone doesn't do anything for cocaine. With luck, people get the opioid addiction under control, and then they sort of start looking around and say, maybe it's time to do something about the other stuff. How clinics sanction this is very, very variable. For instance, in New York, we don't test for marijuana at all. In other states, that might be a red flag, and you might start talking about maybe losing a few take-homes for that. And this varies by state regulations. There's a minimal number of drugs that have to be tested for under federal regs, but the state regs can sort of add them, and the clinics have some discretion. You know, there actually are clinics who breathalyze people because they regard alcohol as a gateway drug. Other is, yeah, it's not great, but if you can stagger in, we'll medicate you. So these are really the two extreme wings, and every clinic will land somewhere in the middle. The three big dangers for methadone patients, comorbidities, tend to be cocaine, alcohol, and benzodiazepines. Benzodiazepines and the alcohol are especially dangerous because they're also systematic depressants.
Thank you very much for that. We have another question that was sent to me privately, so I won't say the person's name. What is the best way for a primary care MD to open the conversation with a patient, in your opinion?
Private MD sees the patient and realizes, you could say, well, you know, I've noticed you've had a few health problems and maybe your clinic attendance hasn't been so great. Are you having difficulties? If so, maybe there are things we can do to help. And in a primary care practice, you might recognize buprenorphine. You might recommend buprenorphine first because it can be prescribed in an office and in primary care. Methadone, you're getting into the clinic system. But it's important to sort of say, we recognize this is a problem for you, otherwise you wouldn't be making it obvious. And we'd like to see how we can help. It's the helping orientation rather than the, you know, got you, you're out of my practice.
Thank you. We have a question here from Michelle McKenzie. If you would like to unmute yourself.
Thank you, Liv. Joe, thank you so much for that presentation. I really enjoyed it. And I really love the idea of a peer-led group in an opioid treatment facility. And I wonder what you think about the requirement, sort of given the era that we're in of in the midst of COVID, and there's been a lot of discussion around telehealth, and there's been just a lot of looking at what all of the regulations around both buprenorphine and methadone. And I wondered if what you think about the requirement, the counseling requirement for methadone, and if there should be a loosening of that and having people be able to choose the way that they want to get their recovery. So if it be with a peer group, if it be in other, any pathway to recovery. I just wonder what your experience was and what your recommendations are around required counseling in methadone clinics.
It depends on what you mean by counseling. Legally, a certain amount of counseling is required because there has to be a central person to keep track of your take homes and attendance and all of this. So usually you go in and you check in with that person for 10 or 15 minutes once a month. That's about it.
Okay.
And that's all that's absolutely necessary. Going to you're required to have access either internally or through another institution to more intensive counseling. Some clinics require other kinds of counseling, period. That's on the psychosocial end of the methadone spectrum as opposed to the medical end.
What is your feeling about requiring that counseling?
Personally, I tend to the medical end. But that's just my bias. Some people will deliberately seek out counseling, or they'll like it, and that should be up to them.
Right.
Especially because the workforce is not always that well trained.
Right. Thank you.
So we have a question here from Diane. Isn't Suboxone, which is safer due to opioid blockers, taking the lead on opioid receptor replacement treatment?
I don't think it's ever going to replace methadone treatment because Suboxone is only effective up to a certain number of milligrams, about 16. And after that, it shifts over being to an opioid antagonist. So if you have a tolerance that is going to require more than 16 or 20, you're not going to feel completely satisfied with Suboxone. That may be a trade-off you deliberately make. I won't feel super great, but I won't have to be in clinic. People with higher tolerances and higher dosages, it's a tough choice. They really do belong in clinics and with all the hassles that involves. Suboxone to me is a great way to get people introduced to medication therapy because it can be prescribed in very low thresholds. And, you get people used to it and they start saying, well, this isn't so bad, and some of them will decide they really need methadone because they're just not being held adequately. Some of them will not, So I don't see them as contradictions at all.
Thank you. Let's see here. So we have a question. Is Suboxone being misused more than methadone? Do you know? Or what information do you have on that?
Well, there's no clear evidence. But there's certainly more access to Suboxone on the street because it is prescribed. And it's not hard to, sell or give a box or two away. With methadone, you usually have to bring the bottles back, the empties. So it's sort of obvious. And there's always been a market for illicit methadone, but it's not that big. The whole issue garners a lot more attention than it really deserves. And most people are not selling their bottles because they know they're going to need them. So there will always be a few methadone sales, but I don't think it's anywhere near Suboxone sales. On the other hand, if I, as an opioid naive person, take a Suboxone, I will get mildly high. If I take somebody's bottle of methadone, I could very easily be dead. There's a big danger in having them around.
Thank you. I'll call on you after, Kevin.
All right.
So Aaron asks, a lot of criticism comes at for-profit methadone clinics, such as accusations they unfairly profit off patients. But I wonder, in places like many cities in Texas, where for-profit methadone is the dominant source of MAT, what you think of the tension between for-profit MAT and the issues with for-profit medicine in these facilities providing essential access, though at a price that otherwise would not be there.
Oh boy. We don't get a choice in this. There are places where nonprofits are willing to open up, other places where for-profits have seen a niche. And there's no consistent quality relationship between the two. There's some for-profit that are very good. They've been run by doctors who wanted to open one and do things the right way. There are some that are basically of methadone clinics, depending on payment source. Some are nonprofit, like ours is university-based. Others are basically large closets. So I have a hard time with it. I don't really know the answer.
Muted. Liv, you're muted.
Sorry, my chat box was in the way. I had it up in front of the screen. Kevin, you can go ahead and ask your question. Thanks.
Okay, it was a lot of information that I was getting in. The question is this, because I was hearing that when people do want or seek methadone as a help or an assistance to what's happening in their life, to their substance use, they have to show that they've been in treatment or some type of recovery prior to that. It's a two-part question. Number one, is methadone a healer or a crutch? That's number one. And number two, does the person, if the withdrawals is off of the opiate, which causes pain, why does that path have to be traveled? Because you're going into treatment, you're going through the withdrawals, you got to prove that you went through the withdrawals because you went through treatment with no assistance, so to speak. And now you go and say, okay, I've done that. Now give me the methadone. Is the methadone a healer or a Band-Aid?
Well, I'm a believer in it as a healer because it frees up your life to do other things. The reason they do that in the early induction stage is to prevent killing you, actually, because there's no reliable way of gauging how much heroin you have on board from your withdrawal symptoms. And so the rule is to, and there have been a number of deaths from inductions and raises that were done too fast. So the rule is to start low and go slow. They're legally restricted, and this is federal reg, from starting any higher than 30 milligrams, which is not a lot. And people are uncomfortable for a little bit. And then you can observe for a few hours and do an additional 10. And then you have the person come back 36 hours later, see how they're doing, and say, all right, we want to go up another 10 milligrams here, until they kind of hit that magic spot. I don't regard it as a crutch, because everybody needs something.
Okay.
This is a medication. It's not,
Okay.
But I'm sorry, what was your other question?
Oh no, that was basically it, because she was giving a lot of information, and then there's a lot of different angles coming at this: the clinical, the professionals, the studies, and all this here. And it seems like it's something that is a lifesaver for those that are really in need. And why is there so many questions or stigmas that would come along with that? That's like putting a stigma on chemotherapy.
That's what we're all wondering. Thank you. We regard it as kind of the same thing. Why is it such a big deal? Except that street heroin users are not terribly popular people. It's associated with that. And it's somewhat racialized. That's a reality too. But as far as we're concerned, this is why many of us lean to the medical side of things. This is a medical treatment. Don't go getting this other stuff into it. Would they do it to me if I needed an insulin shot? No.
Okay. Thank you.
Yeah, one thing that, I have seen, John always give the example of in his stigma trainings is, you're not going to get mad at somebody who, has had cancer for, having another flare up, but you're going to punish a person who has substance use disorder as soon as they have a reoccurrence, So it's like we remove treatment the second that treatment is at the, needed the most. And I think that, calling, MAT just medication is one of, the first steps of getting to a better place with that stigma, helping reduce it. That's my little 2 cents. But now we do have another question, unless you did have a comment on that one. Let's see. So what does the decision to stop being on methadone typically look and feel like for a patient? Are clinicians typically supportive of patients who have this goal, or do they push for longer periods of maintenance?
They vary. Most will push for longer periods of maintenance, because when you get off heroin, your body is kind of stripped of its protective stuff, and you're very prone to an overdose. The receptors have been plugged for a long time. It's famously not so easy to get off methadone. It's not necessarily hard, but it takes a long time. You have to do very, very gradual reductions so that your body doesn't feel it and start wanting, oh my God, I need another opioid now. So this is where it gets a bad rep, that you can't just walk off it the way or you can, but you'd probably be dead from an overdose. But people do feel being kind of trapped over the long haul.
Thank you. Someone asked Myra, I'm curious, what is the highest dose of meth can a person receive?
Well, there's no set limit, except some clinics may have dose ceilings. It's not regarded as good practice anymore, but it's not technically illegal. You keep going up slowly until people are feeling okay. They're no longer craving. They're responding fairly normally. That said, I personally knew somebody who was on 1200. Granted, she had pain problems and whatnot. But dosages up in the 400s are not unknown. The thing you start worrying about when you go with dosages that high is, what if I'm hospitalized? Are they going to give me that much? If I do want to get off, how many centuries will it take me? So a lot of people stay at, and there's this kind of moral idea sometimes too, that you're better off at lower dosages.
Thank you. So I had a question actually. All right, so, hearing all the parameters that there are in order to, prescribe this to people, it like, I'm not comparing the two, but it almost feels like, when they started making all different laws on what abortion clinics could be like, from like the size of the room to like, how many chairs are in the waiting room, just really weird things that have nothing to do with anything. Do you think that if some of these barriers were a little bit more lax, do you think that, number one, more people would be in treatment slash maybe the treatment would look a little bit, I don't know, not more acceptable, but be more accepted in the actual recovery community?
I think it's whether it will be completely acceptable, I don't know. But part of the stigma is the having to go to the clinic routinely, and most clinics are not in prime pieces of real estate. You associate with people who are not always aesthetic, and you're getting this stuff which is regarded as sort of polluted. So the fewer restrictions, the better. It's funny that you should mention the comparison to abortion services, because one of my professional colleagues who is on the call has been exploring the notion of intervention stigma, where it's not just the people or the procedure, it's the whole medical intervention that has a cloud or stigma around it. And she's identified both abortion and methadone as the two so far.
That's very interesting to hear. I look forward to hearing more about that.
What happens when people are hospitalized? Most clinics will have a 24-hour emergency number that someone has to respond to, and you'll always have a clinic ID. When the hospital admits you, they will call to find out what your normal dose is and continue it inpatient. Now, this is what you hope happens. It doesn't always, and sometimes doctors get other ideas. The idea of being hospitalized kind of frightens people. And you're out of control. They take your bottles from you, and they have to bring you the stuff.
Was there another? Can I say something? I was listening to this, and as I become more educated in recovery, and I hear the different views on recovery and science, and what it seems like to me, now this is just the way my mind is working right now, it seems like you have a philosophy, which is with the core of something, how something begins. And then you have the science. The science is the effect. And recovery lays in the middle of the philosophy and the science, because it seems like we have in recovery, you have different philosophies, the 12-step, this, and this. And then you have the science part of it, and the recovery sits in the middle. You basically meet them where they're at. And the reason why I'm saying that right now is because I was listening to your lecture and how you was talking. And that was the information that I was gathering in my head, And then as you said things, that question, please forgive me for using the word crutch, when it came to the methadone, because that's not how I meant it. It seems like the withdrawal, the physical withdrawals and the mental withdrawals from the opiate is so powerful. It's something to hold on to make you feel safe. That's why I asked that question like I did. But I see the philosophy part of it now and the science part, and then recovery sits in the middle. And it's like we're trying to, in our hearts and minds, bring these two the philosophy and the science together.
Pretty much, yeah.
Okay.
Thank you, Kevin.
Thank you, Liv.
Now, does anyone else have any questions or comments? I can give everybody another minute.
I'm happy to be.
I'm sorry?
I'm happy to be here. I don't feel super rushed.
I'm having a little trouble here, and I'm sorry. I'm not sure if it's my computer.
One of the things that we suffer from in the addictions field is it's so isolated from the mainstream. It tends to go into psychology and social work, and yet sometimes but it's like, well, what do they have to say? And I have to say, one of the most rewarding parts of the whole time I've spent with Mars is at some point, Walter thought, what we need to do is make more of an impact in Albany, go up there and kind of lobby for more funding for our kinds of programs. And in other words, do what everybody else did. So they actually got 2 buses of methadone patients together, set up with little folders for legislative appointments, and got them to and from Albany. It was the first time ever. And people came back, and they'd never been to Albany, but they also looked around and said, you mean we have representatives and they work here for us? It was really very nice.
Thank you. We have a question here from Aaron. Was Mars created because of rejection of MAT patients from NA spaces, or was that not a major driver?
That was kind of a major driver. It was regarded, other spaces were regarded just as lost causes. We have our own distinctive, not only treatment system, but the issue of the medication. I have to say that once we were sort of in the government recovery space, SAMHSA and whatnot, the welcome was not altogether friendly, and still isn't. I had an unpleasant experience just a few nights ago with one of the national recovery organizations.
What did they say to you, Joe?
If you can say.
They didn't say. There was a poll at the beginning of the 200-person discussion asking which pathways of recovery do you support? And I went and checked off a few, and I said, wait a minute. Those of us who support medication stuff are just kind of invisible in this. And that's so typical.
So it wasn't even an option?
No, it wasn't. It's just like we're somehow defined as not in a pathway of recovery, despite the efforts for years to promote the idea of medication-assisted recovery.
Wow, that's actually kind of surprising to me personally, but.
I think we've been pretty lucky in Rhode Island, all things considered.
That
But
too.
there's more to be done, for sure.
All right, well, if anybody has any last minute questions, I'm sure we can all be in contact. You know, I can send you any questions if somebody, you know, thinks of one right after we get off, but I don't want to.
That's how it usually happens.
I'm sorry?
Usually when things are over, like, you end up thinking of a question or something you want to ask.
Right, exactly. So I'll put my email in the chat right now. You can reach out to me with any questions you may have for Joe if they come up. And I just want to thank you on behalf of Rikers and Cobrae and Brown as well, just for coming and, you know, giving up your talk to us. Definitely get your notes to me, and anybody who wants those, you can reach out to me as well. And thank you so much, Joe.